link in excluding infrarenal aortic or aortoiliac aneurysms, and to report the data of PowerLink implants, especially regarding in difficulties during implants and early complications. Our selection criteria: patients ASA 2 to 4, at least 4.5 centimeters aortic diameter, proximal neck diameter less than 26, proximal neck length at least 15 millimeters, no patient excluding regarding proximal neck angulation or iliac tortuosity or calcification. I would like to remind you that all measurements were taken using CT scan and angiogram. The exclusion criteria: serum creatinine level more than 2 milligrams, inferior mesenteric artery blood flow crucial to prevent bowel ischemia, chronic anticoagulant therapy, and mycotic aneurysm. Let's take a look at the main features of the device. You can see here it's an one-piece only bifurcated PTF-covered self-expandable device with two diameters in the aortic segment, 25 and 28 millimeters to length, 135 and 155. It has one iliac diameter that is 16 millimeters, with or without bar stent. The extensions, the aortic calves, are with or without bar stents, and they come in 28 and 25 millimeters in diameter, and the iliac segments that are without bar stent are in 88 and 55 millimeters in length. The oversizing ranges 12 to 35% and allows a one-size-fits-all approach. The skeleton is self-expanding, no needle or metal alloy, cellulose body, double spine, and a single wire body. Our results: we treat 60 patients, 56 men, with a mean age of 71 years old, with vascular disease in other critical areas in 47 patients, type 2 diabetes in 19, type 1 diabetes 4, hypertension 42, hostile abdomen 16, and horseshoe kidney 1. The mean follow-up was 7 months, and we deployed 60 endograph, 43 of them with transrenal fixation because of shorter angulated necks. We define primary technical success as 30-day survival with endovascular aneurysm exclusion-free of Endolix, and we achieved that in 55 patients, 91.6%. 2 patients were converted to open surgery because of anatomical risk factor combined, excessive proximal neck angulation and iliac calcification and tortuosity. The mean intensive care unit stay was 1.5 days, the mean hospital stay was 3 days, and the 30-day mortality was 3 patients because of unrelated reasons: stroke, myocardial infarction, and car accident. In reference to the Endolix, 12 of them were detected during procedures. 9 were closed with secondary endovascular maneuvers with 5 proximal calves, 3 distal extensions, and 1 stent at the proximal neck. 3 were small distal type 1 Endolix and sealed spontaneously, in the 1 month follow-up with CT scan and angiogram. We had 1 limb occlusion 30 days post-implant asymptomatic. This patient developed a proximal type 1 Endolix. I will show you later this case. We complete the 3 months follow-up in 42 patients, the 6 months follow-up in 29, and the 12 months follow-up in 12 patients. In reference to the complications, you can see that the inflammatory syndrome in 18 cases was the most frequent one. Then we had puncture site hematoma in 6 cases, superficial wound infections in 3, and 2 persistent buttock claudication in the group of patients with aortoiliac aneurysms, in which we exclude the internal iliac artery. Also important, the complications that not happen, like no distal artery embolism, no late ruptures, no late surgical conversions, no evidence of device migration or Y fractures, and no statistically significant changes happened in the serum creatinine level in patients with transrenal fixation. Also, no renal osseous was lost with or because of strats in patients with transrenal fixation. Let's take a look of PowerLink versatility and how to handle some difficulties. We are showing now some examples treated with different sources. In this case, you have this type 1 Endolix treated with balloon with the result that you see there. In this case, with an angulated neck, we use latex ballooning to treat this type 1 Endolix with this result. In this case, just a calf to treat this type 1 Endolix with this result. In this case, you have this large neck with a sac with this type 1 Endolix, and deployment of a cuff and PTA ballooning with this result. We use a couple of times this stent, that is a titanium stent used for the aortic coarctation, and it is deployed with this balloon. There's a balloon inside another one. You can inflate the inside balloon and relocate the stent in the position that you want. You can see here this very difficult case for this particular device with a very tight area here in the neck. We had this type 1 endoleak in the beginning. This is the deployment of the titanium stent that I told you, and the result without endoleak, like you can see here. This is the patient I referred before in reference to the occlusion of the asymptomatic of the right limb that developed a proximal type 1 endoleak 1 year later, and treated also with this titanium stent with the result that you can see here. A couple of challenging cases. You can see here an aortoiliac aneurysm, well, treated with contralateral approach and coiling of the internal iliac artery, and well, the endographing position with an extension to the external iliac artery. This case, this patient that who has a very high risk because he's a physician, he's a vascular surgeon. He has this CT scan 1 month previous to the treatment with the cava vein patent, and you can see here how we admit the patient in the hospital with a cava vein occlusion. You can see here the cava vein and the venogram. We have to deploy a filter first and then to treat the aneurysm. As you can see here, the filter in position and the aneurysm. And the result, we have an initial type 1 endoleak, you can see here, treated with balloon with this final result. This is the 1 month follow-up. Look at the leg. He has a superficial groin infection, just that. And the last case I will show you, this is a small aortic aneurysm with 2 big common iliac aneurysms without the internal iliac patent. And you can see here the treatment with endograph with 2 extensions to both external iliac arteries. In conclusion, technical success in 5 Argentine institutions in their earliest experience with PowerLink device has been satisfactory. Complications rate was low, mean blood loss was 140 milliliters. Most technical endograph problems in this experience have been related to patient selection and not to the device itself. PowerLink is a safe and easy device to exclude AAA. Our mean implant time was 13 minutes, and long-term results are pending. Ladies and gentlemen, thank you very much for your kind attention.
Thank you very much. May I call Professor Espinosa to the podium, please? And he's going to talk on the initial results